Hello, everyone. Welcome to the Multiple Myeloma 360 series, Part 1, the latest treatment options, specifically in the relapsed and refractory setting. I'm Tiffany Drummond, a patient advocate with over 20 years of experience in cancer research. But my journey as a caregiver began when my mother was diagnosed with endometrial cancer in 2014. I quickly realized the challenges of finding resources, support, and shared experiences. And now I'm committed to helping others avoid similar difficulties, no matter the condition. That's why we at The Patient Story create programs like today's to help you figure out what comes next. Think of us as your go to guide for navigating not only the cancer journey, but your overall health journey. From diagnosis to treatment, we've got you covered with real life patient stories and educational programming with subject matter experts. I genuinely am your personal cheerleader, here to help you and your loved ones best communicate with your healthcare team as you go from diagnosis through treatment and survivorship. Before we get to our speakers, we want to thank our sponsor, J&J, for its support, which helps us to host more of these programs for free to our audience. The Patient Story retains full editorial control over all content, as always. And I must also thank all of our promotional partners for their support. It is because of you that our programming reaches the audience who needs it. I hope you all find today's program helpful, but please keep in mind that the information provided is not a substitute for medical advice. Finally, we know there's a lot you want to know more about and discuss, or at least tune into. So please let us know what those topics are, along with what we could do better. A survey will pop up after the program ends, so don't go anywhere. Without further ado, let's kick off another amazing conversation. Thanks, everyone, for joining me today. I am here with The Patient Story, and I have two amazing guests that I want to introduce you to as we talk about the latest treatment options in multiple myeloma. I am joined by hematologist and oncologist, Dr. Ola Landgren. So Dr. Landgren serves as professor of medicine and division chief of myeloma in the Department of Medicine. He is the director of the Sylvester Myeloma Institute at the Sylvester Comprehensive Cancer Center and co-leader of the Translational and Clinical Oncology Program at the University of Miami. So we are so happy to have you here, Dr. Langren. Thank you so much for taking the time to be with us today. And also, I'm excited for you to meet and introduce you to our moderator today, who is going to be Kenny. And I'm going to let Kenny introduce himself because he is a ball of energy. So I'm going to let him do that. But just know that he is a multiple myeloma survivor and thriver. So Kenny, I will let you take it away. Tell us a little bit about yourself, and the floor is yours.
Thanks, Tiffany. And hello, everyone. So my name is Kenny Capps, and I'm honored to be your moderator today. So I'm the executive director of Cancer Active, a nonprofit organization dedicated to empowering those infected by cancer to live active and fulfilling lives. And I've been on my own journey with multiple myeloma since 2014. I understand many of the challenges that you, as patients, must navigate. I was diagnosed relatively young, at the age of 42, and have lots of bone involvement, spinal compression fractures, and lesions. I've undergone infusions and a bone marrow transplant. I've lost count of how many bone marrow biopsies I've had. In 2023, I relapsed, changed therapies, and added radiation treatment to the list of things I've never done before. I did all this while raising 3 kids, training 30 to 70 miles a week, running 1,200 miles across the state of North Carolina, and experiencing all the celebrations and heartbreaks that come with life, regardless of whether you're treating cancer or not. I've had many experiences and a lot of education as an athlete, a coach, an attorney, and a father. And 10 years ago, I combined all of those experiences to become a patient advocate and a cancer active leader. So today, we're fortunate enough to have one of the leading voices in multiple myeloma research and treatment with us, Dr. Landgren. Dr. Landgren is not only a pioneer in advancing care for this disease, but he's also deeply committed to translating cutting-edge science into real human-centered solutions for patients like you and me. His work has helped reshape how we understand and treat multiple myeloma, giving us more options and more hope than ever before. Today's conversation is all about you. We'll explore the latest in treatment options, emerging research, and most importantly, answer your questions in a way that makes this topic understandable and actionable. So, thank you for being here. for asking questions, for being part of this community. And now it's my privilege to introduce our distinguished guest, Dr. Carl Ola Landgren. Dr. Landgren, thank you for joining us.
Thank you very much for having me here today. It's really a great pleasure and a great honor being on the show. Thank you.
So I'll go ahead and jump into our questions, and our audience is going to be pretty savvy because most of the people that are watching this have concerns and they already know what it is they don't know. So they're extended that. So, but for those who are unfamiliar with the term relapsed or refractory in the multiple myeloma setting, could you break that down, what that means?
So I think in lay language, relapse and refractory refers to the fact that the multiple myeloma disease becomes active again. So someone who is newly diagnosed would typically receive combination therapy with or without transplantations, typically with continued therapy, we also call maintenance therapy. As we follow an individual that's treated this way, unfortunately, over time, the majority of patients will at some point have the disease becoming active again. And this is because we do not yet have an established cure for the disease. The patient can, in 2024, in 2025 and onwards, I think many patients can live for 10, 20 plus years. And I think there will be patients that will not have shortening of their lifespan, which is how the field is going forward. For now, the disease will be managed for the most part as a chronic disease. We are trying to develop definitive cures for the disease. So coming back to your question, as we treat it as a chronic disease, if there is reappearance typically of proteins in the blood, if there are rising levels, if there are any other clinical suspicions going on that would trigger, say, additional radiological assessments, say with PET CTs or MRIs, or if we do bone marrow biopsies, if we see there is more disease, that would be consistent with the disease becoming active again. And that's what relapse refractory is. I should also say, when we do clinical trials, we have rule books for what is what. We have a rule book for what's called a partial response, what's a complete response, what MRD negativity is. And we also have rules for what progressive disease is and how to capture that. The reason we have that is because if we don't have a common language, we cannot compare the results across different trials. So that's very important. We worked on that for over 20 years as a community. So in the setting of those rules, a relapse or relapse refractory disease refers to a situation when a patient has rising levels of markers by these definitions we have, either while being on a given therapy, or we arbitrarily made a decision a long time ago saying if it happens within 60 days after stopping the therapy, that would also count as a relapse refractory state. So these are the technical details of that same question.
So with regards to refractory, does that mean that they are unable to continue along that line of treatment?
It's a very good question. So I would say that the word refractory, I think, carries probably more focus on things that are not really true, meaning that you cannot go back and use that treatment than it really is. So I think in reality, what it really means is that right now, this is not the optimal therapy to use going forward at this time. But to revisit and go back and use that drug in the future, maybe in combination with other drugs at a later time point, is something we very frequently do. So we sort of recycle the drugs. So let's say an example could be you use a proteasome inhibitor, an IMiD, a steroid, say with a CD38 targeted antibody as a combination therapy. And you give that for a certain number of cycles. You may collect stem cells. You give maybe more cycles. You may do a transplant or not. You may go to maintenance therapy. You may have an IMiD at a lower dose with a CD38 targeted antibody. And eventually you may step down to a single drug IMiD. Many years later, maybe there is reappearance of the protein in the blood. Could you go back and use a proteasome inhibitor? Yes, you can. Could you go back and use the CD38 targeted antibody? Yes, you can. Is it the best thing to do to use that same IMiD at the same dose level? Probably not, because the disease was able to grow through that. What about increasing the dose? Probably not the best option right now. So maybe switch to another IMiD or some other drug. And then you can overcome this reappearance or relapse we are talking about. And you can get very many more years with the same benefit. You get rid of the disease, you keep the disease away from becoming active. Now, if the disease comes back again, could you now ask the same question? Could you go back to those same drugs, including the first IMiD? I would think yes. So you could think about using the same drugs over and over again. But what's happening is that there are so many new drugs coming to the field. So we are many times going to new mechanisms of action as the next step forward. But at some point, when you have used all the different mechanisms of action, we will go back and recycle. And we will use them in different combinations. What we look at is drugs that had a good benefit, that were not too toxic for this patient, and there were no other contraindications, and try to see how we can partner them maybe with other drugs than we did the previous time we gave them. So that's a basic way of summarizing this topic.
Well, and when you're saying that, what I think about is what at least used to feel like it was somewhat standard of lenalidomide, Velcade, dexamethasone therapy, and then maybe with a maintenance therapy after a bone marrow transplant. But at some point, a patient might stop responding to that 5 or 10 milligrams of lenalidomide at some point in the future. So you're saying that they could switch over to another supplement, so maybe pomalidomide at some point as a substitute for that. But that doesn't discount the possibility that lenalidomide might be in the future a solution for them.
That's exactly right. And if you look at how these drugs have been developed over time, they have been developed for certain indications. So you mentioned pomalidomide as the next move, and that's sort of the example I gave between the lines. I didn't mention drugs, but you filled in the blanks there. All the drugs you gave were probably the drugs that, for the most part, would fit with the example I gave. So pomalidomide was developed in 2006, and it was given to a patient that had failed lenalidomide. And that's how the FDA approval was granted. So it's a logical thing to do. But what has not been done on a trial level is to do studies where you then go back and revisit to lenalidomide at a later time point. So why is that? Well, it's because the drugs are approved, and once they are approved, then they are commercially available and we can prescribe them. But it actually addresses another important topic, and that's the so-called real-world evidence. And that's where people like me come into play. So I have been a doctor for 29 years at this time. I've treated probably thousands of patients, and I've used all the drugs that were FDA approved. I've worked on very many clinical trials, phase 1 and phase 2 studies, and also some of the phase 3 trials, but mostly phase 1 or phase 2 studies. So I have a lot of experience with these drugs. And when people like me are using the drugs every day in our clinics, we learn how to do what we are talking about, how to use these drugs in a recycled manner for patients that have the disease coming back. And sometimes we document on these things, and many times when we, like today, we talk about it. So when I'm at meetings, many colleagues that maybe see fewer patients could come up and ask and get advice. And we try to share our experience with each other, and that's how we help each other as a community.
I love it. And I'm looking forward to those possible trials in the future. So given the evolving landscape of myeloma treatment, what are the current estimates for the percentage of patients who experience relapse or becoming refractory to initial therapy? So how do factors such as patient age, disease stage, and genetic risk profile influence these rates?
So I think if you look at the population databases that are currently available, unfortunately, as I said before, we do not have an established cure. So for these reasons, the majority of patients at some point will have the disease becoming active again. If you look through databases that have been published and presented, there is a small group of patients where the disease actually does not come back again. So I think that's an important piece to first point out, that I think the disease is curable. The problem is that the disease is very different from patient to patient. We call it genomically heterogeneous. It's not the same disease in every patient. When we profile the disease, we can see that the average patient has a few thousand mutations if you perform whole genome sequencing. And you can also see alterations in the immune system. So with a disease that is so different from patient to patient, it's obviously not surprising when you give the same therapy to everyone that the outcome would be different. So that's why we say there's different prognosis. And people have talked about high risk or standard risk in this very setting. So now adding another dimension to this conversation, the concept of high-risk disease is a moving target. So if you have a weaker treatment and you treat 1,000 patients, more patients will not benefit from that weaker treatment for the reasons I just gave, because the disease biology could be such that it's stronger than the therapy over time and it will come back sooner. But as the treatment gets better and better and better, more and more patients can benefit from the therapies. And there will be fewer patients having the disease returning sooner. So for that reason, the so-called high-risk group is a shrinking species. And it's always in the light of how you treat. And I think ultimately, with the best available therapy, there is no high-risk disease. And we could also envision a scenario of a cure. So coming back to your question, when you say what's the rate of relapse, it is in the light of how we treat. But in 2024 and 2025, we still don't have a definitive cure. So the majority statistically will have the disease coming back. But what's different at this time compared to, say, 10 or 20 years ago, when I was in fellowship over 25 years ago, the duration of the benefit of therapy is drastically different. When I was in fellowship, the disease from diagnosis to a patient passing away from the disease could be only 1 or 2 years. I have many patients who are 20 years out and they're doing great. And I think many of those patients, they will not die due to myeloma. We will all die at some point. But I think many people will probably die with myeloma, but not from myeloma, which is a huge change.
Yeah, and that's a huge phrase that I hear more and more. And yeah, that's good to hear.
So if we can hold the disease away and people can have good quality of life and have no shortening of lifespan, that's a huge deliverable. And I think for many patients, we already are at that point. But there may have to be changes of the treatment. So the disease will probably come back for the majority. And we are trying to develop curative strategies that are definitively curative. So that's something we are working on. I don't know if I answered your question good enough.
You did, and that leads me to my next series of questions, because I'd like to you mentioned quality of life. And so that's impacted by side effects, but it also is impacted by the treatment itself. So which sometimes is progression of the disease, sometimes it's, again, side effects from treatment, but sometimes it's also the psychosocial challenges that patients have to deal with from day to day, that negatively impact how they feel, what their life is. So, but also, with the treatments, as you mentioned, over the past 10, 20, 25 years has changed dramatically. So in the context of the relapsed refractory multiple myeloma now, today, does traditional chemotherapy still have a role to play? In the world of, IMiDs and CD38 treatment and bone marrow transplants and CAR T, is chemo still used?
Well, I think we don't want to stop using drugs that we know work until we have a definitive cure. So you want to keep all the different options, all the doors option. We want to have all the doors open. But I think the order and the priority of the different therapies will probably continue to change. So again, I was mentioning when I was in fellowship, the therapies were very, very inferior. The overall survival was 1 to 2 years. The remission rates were single digit. These days, if I treat, I would achieve remission rates 95+%. I have MOD negativity rates in my newly diagnosed patients over 70%. And for the majority of my patients, I don't use any chemotherapy. And we have also for many years explored if you could harvest the stem cells and hold them, so you could also not go for a transplant. Transplant is chemotherapy. In the United States, it's called transplant. In Europe, it's called high-dose chemotherapy. And it is chemotherapy because it's melphalan chemotherapy. And the stem cells are not part of the treatment. They are just a way to recover from the chemotherapy. So I think that there will be shifts away from chemotherapy. And I think we will see more and more of the immunotherapies coming. I think the new antibodies are coming. The CD38 targeted antibodies are coming with full speed, but there are also new antibodies with new targets that are coming. And we also see the FDA in 2024 approved CAR T-cells for the first relapse. So more and more immunotherapies are coming. But will that mean that the chemotherapies will go away? I don't think so, not until we have a cure. So I think the role for these therapies potentially will be shifted, that they will be options maybe if patients have later line relapses. But if you have immunotherapies up front, if there is recurrence, there are more immunotherapies. If there is a recurrence again, there are more immunotherapies. There are more immunotherapies, and there are small molecules, but eventually maybe the chemotherapies will be part of it. And there will be patients that will be outliers from this principle. I see patients where the chemotherapy drugs or the most tumor-sensitive drugs. So some patients, when we give the immunotherapies, they don't do as well. But those patients are, I would say, a minority. But there are patients like that. So it's good to have options.
So could you discuss further the differences between the bispecifics and CAR T therapy?
So a bispecific antibody is exactly what the name tells you. It's bi, so it's two, and it's specific. So it's specific in that sense that it goes for myeloma. And the other specific is that it is linked towards immune cells, T cells. So the way these antibodies are engineered is that they have two heads. One head binds to a protein on the surface of the myeloma cells, and the other head binds on a surface marker on the T cell. On the T cell, CD3 is the marker. For the myeloma cells, there are currently two approved antibodies that have two different targets. There's BCMA, and there is one that has GPRC5D as the targets. So there are in total 3 bispecific antibodies approved for multiple myeloma. So all of these antibodies, they bind to CD3, which brings the T cells to the antibody. So they hold on to a T cell. And then when they grab the myeloma cell with the other marker, that means that the myeloma cell is now sitting neighbor with the T cell. And the T cell will then do the job of killing the myeloma cell. That's how the bispecific antibodies work. The CAR T-cells refer to, is an acronym for chimeric antigen T-cells, or chimeric antigen receptor T-cells. So what that means is that you can take out T-cells from the blood of a person. They circulate in the blood. They are not stem cells. They're not the type of cells you would collect for a transplant. These are just circulating immune T-cells. And you take them out, and then you can send them to an approved facility that follows all the guidelines and the regulations the FDA has set up. And they will do something called a transduction of these T cells. So that means that they are being exposed to a genomic vector that will change the DNA in these cells. And the change means that they insert certain information in the cells that has an instruction for these T cells to do things that they normally wouldn't do. And the instruction,
which is to die, basically.
No, it's actually to develop like an antenna on their surface, and that is what the receptor is. So they are the same T cells, plus that they read this instruction that says, make this receptor on your surface. So that's what they do. Other than that, they do the same job they normally would do. And then you feed them with glucose and nutrients, and you keep them warm. And then about 4 to 6 weeks later, in the current environment, in the current development setting, you give them back to the person that gave these T cells to the facility. And when they re-enter the body, they will be let in because the body will say, these are my own T cells. And when they come in, they are now programmed with this receptor, like antenna on the surface, to bind to something that fits with the binding site of the receptor. And that is this BCMA protein I was talking about before. So when they come in, they look for this protein and they bind to it. And when they do, same as the bispecific antibodies, now a T cell is neighbor to a myeloma cell. And when it sees the myeloma cell, it will kill it. So in a way, both the bispecific antibodies and the CAR T-cells are sort of doing the same thing. They take advantage of T-cells as the medicine, if you want. So in one setting, you keep the T-cells in the body and you give a matchmaker, which is the antibody. In the other example, you take out the T-cells and you modify them and give them back. And there are a lot of other ways of doing it. You can have donors giving blood where you can make something called allogeneic CAR T-cells, which is basically a mass-produced CAR T-cell that comes from a pool of donors where you give that to multiple patients. And the idea there is that you can give it, say, next week, because there is no need to first harvest them and then manufacture them and give them back. You just have donor-derived T-cells. There are not yet any approved such for myeloma. There are also other technologies where you can insert what's called mRNA made both T cells and bispecifics. So similar to how the COVID vaccines were developed, you can use mRNA infusions to synthesize these types of products within the body. That has not yet happened in humans, but there are a lot of animal models. And I think in 2025, we will see how these mRNA-based technologies will probably speed up the whole development of immunotherapies. This is going to be very, very exciting.
So are there specific patient populations that are more geared toward or most likely to benefit from bispecific antibody therapy?
There is currently no head-to-head randomized study that has compared, say, 100 patients given a bispecific antibody and 100 patients given a CAR T-cell. That study has not yet been done, comparing them head-to-head with each other. All the studies have compared CAR T-cells to older combination therapies or the bispecifics compared to older combination therapies. So again, there is no head-to-head between the two of them. What we do know is that if a patient has an activation of the disease or there is a relapse, the majority of patients have usually a slower evolution of the disease. The disease usually shows up as a blood test with the protein markers going up. And it can go on for many weeks or even months before you start making decisions to really change the therapy. So you have some time to make treatment decisions. But there are some patients where the disease can change rapidly and it can turn into a lot of symptoms. So if you have someone with the disease becoming active in a short time window, you really cannot wait to collect the T cells, send them for manufacturing, holding the disease under control with some other what we call bridge therapy, and then give back the CAR T cells. So maybe the bispecific antibodies is the better option for many of those patients. And in fact, usually that's how it goes. But if you have patients where the disease is moving more slowly, you have the two options. And you could argue which is better. And I would say different experts will have different opinions. And in my experience, also, different patients will have different opinions. I think the jury is still out, which is the right sequence. If you should first do a CAR T cell and then at a later time point do a bispecific or vice versa. There are so many details when it comes to this, and we just don't have the data to fully answer. But some of the high points are that if you treat someone with a CAR T cell therapy, on average, it would last for many years. But if a patient, God forbid, have a shorter benefit, if it's a 6 or 12 months, to go right to a bispecific with the same target usually doesn't work because it's too tight in time. But if you go back to another therapy with another target, another mechanism of action, could you revisit that same target using a bispecific? And I would say the answer is, for the most part, yes. And it comes back to what I spoke about before when I said recycling of drugs or targets. Could you do the same thing if you started with a bispecific? Could you in the future go to a CAR T cell? I think yes, with the same target. But if you go back to back, that may not be the optimal way, because if the cells build up some form of resistance to that same mechanism of action, you want to sort of distract the cells by doing something else and bring down the disease. And if you get good mileage out of that, if you need to switch again, maybe that could be the time to go back to that same target.
So we back to side effects and quality of life issues for patients that are using bispecifics or being treated with bispecifics. Could you discuss sort of the most common side effects and how they are managed for those patients?
So I would say that compared to bone marrow transplant, the CAR T cells are way less toxic. The patient experience with the CAR T cell, I would say, is just that, this was much easier. I've seen patients that were transplanted years ago that got CAR T cells, and they said this was really not even comparable. I have had patients, my oldest patient right now just turned 87 years old, got CAR T cell when he was 86 years old. We would not transplant an 86-year-old, but CAR T cells you could give. I've also treated patients that are in that age category with bispecifics. I have many patients that have done that, and they do extremely well. So I think on average, both the CAR T cells and the bispecifics are very, very well tolerated overall. But everything has some form of side effect. If there is no side effects, usually there is no effect, unfortunately. So what are the side effects you see? So in a simple way, when you give a CAR T cell product, you would expect to see something called cytokine release syndrome, also abbreviated CRS. And that means that your immune system gets triggered by this immunotherapy, and it releases a lot of these substances that the immune system uses to communicate with different immune cells and other surrounding cells. These are the cytokines and chemokines. And when they get released, it leads to an immune reaction. So it's sort of an ramped up version of you get sick by an infection or inflammation type of thing. Those types of symptoms like fever, you just don't feel well, and you could have organs responding to it. The blood pressure could go down and things like that. For reasons we don't fully understand, when you give the cilta-cel CAR T cell, usually it takes about a week for this to kick in. Presumably that is probably the time window it takes for the CAR T cell product to really amplify up and expand and become fully active. But if you look at the alternative product called ide-cel, there are two approved products. When you give that, usually the same phenomena with the CRS happens, say the next day, something like that. So the time windows are different for these different products for reasons we don't completely understand. The duration of it is usually 1 to a few days. And if the patient has fever, we can actually treat it like with Tylenol or things like that. You can also give steroids. But if it's a little bit more stronger, we would give something called IL-6 receptor inhibitors. There's a drug called tocilizumab that we use quite frequently, and usually that takes the edge of it. We may have to give IV fluids if the blood pressure goes down a little bit. Unfortunately, there are some patients that get a little bit more sick, and we may have to give them additional other drugs. But for the most part, it is something that is very, very manageable, and the majority of patients don't have a severe side effects, as I started off saying. When this has leveled off for a CAR T cell product, usually the patient would leave the hospital if the patient was admitted. Many institutions, including ours in Miami, we now can do this outpatient. So we can actually have the patient coming, we can give the CAR T cells, we can have the patient being in proximity to our institution, and if the patient were to develop these symptoms, we would treat it along the lines of what I said. We may have to admit the patient after a week for 1 or 2 or 3 nights, and then we can discharge the patient again. And that's the whole experience for the patient, which is pretty amazing, actually. We would do labs, say, once a week for a few weeks to make sure that all the counts are stable. And then we would do, say, once a month. And then eventually we would do every 3 months. We would keep the patient on prophylactic medications for antivirals and antibiotics. We usually will give infusions with IVIG, which means that we supplement immunoglobulin G levels to keep the patient free from infections. Over time, all these things will be taken off. And for the average patient, the patient could be off therapy for many years and just say do blood tests every 3 months. For the bispecific antibodies, you see the same CRS phenomenon. If you look at the registrational trials that are led to the approval of these drugs, the rates are actually quite high. It's over usually 70 or up to 80 or something like that % of patients that develop CRS, even with the bispecific antibodies. Most of them are less intense, so they are also along the lines of what I said, like with fever, it could be drops of blood pressure, things like that. But nevertheless, the FDA has put in the USPI or the FDA labels language saying that the so-called step-up dosing, the first few doses, should be done in patients. That's in order to monitor and see if the patient develop these things, which the majority of patients do if you just follow the standard trajectory or the standard recommendations. So our group at University of Miami has used pre-medication with a single dose of this IL-6 receptor inhibitor. We're given one dose 1 hour before the very first dose of a bispecific antibody. And we presented this at ASH 2024 in San Diego, showing that you can decrease that rate of CRS to, say, 10%. And they virtually are always the lowest grade, grade 1. I think there's a huge step forward. This really sets the stage, I think, for thinking about doing this outpatient. If you can pre-medicate and avoid 9 in 10 patients from having any symptoms, and if you have symptoms that you could have that patient guided on the phone, having to maybe come in and you may have to monitor or you have to do something, some intervention maybe overnight, that's a huge improvement. So I think pre-medications, should be part of the next step, and we are working on that with other groups. I hope in 2025 that these therapies could also be given outpatients. That's something we are working on.
And that leads to my questions. My next question that I was leading right into was discussing about the clinical trials and patient support. And so what do you see as the most promising areas of investigation in terms of the bispecific antibody development?
So I will tell you what I think are the most important trials I see right now. But I first want to say that an important side effect profile for the antibodies is also infection. So what I have seen firsthand, because I've been involved in this for a very long time with the drug development, and I worked here in Miami, I was the chief for Sloan Kettering myeloma program for many years. So we were involved a lot in these early developments for many years. What we don't want is that we develop great drugs that hold the myeloma away and make patients have good quality of life, but then there could be other problems arising, such as infections. So I think it's very important for physicians that treat patients with these bispecifics that they keep an eye on the immunoglobulin G levels and that they use proper antibiotic and antiviral medications so patients don't run into opportunistic infections that could actually be very dangerous. I think that's important to emphasize. So we would monitor, so the immediate side effects we can pre-medicate, but really the doctors need to stay on top of it. And patients also need to know that if you do develop an infection, that you should always alert your doctor. Coming back to your question on important trials, I think that we will see more and more trials with these bispecifics that will use combinations. So at this ASH, we saw combinations of 2 bispecifics. You had both BCMA CD3 and GPRC5D and CD3. This is the redirect trial. It has been discussed at prior meetings, but there were more patients this time. You see very high rates of response. You also see how BCMA CD3 is partnered with, say, lenalidomide, or BCMA CD3 was partnered with a proteasome inhibitor, carfilzomib, from the Magnus-Dilson 20 study. And there are many other studies as well. So what I'm talking about are combinations with these bispecifics and other drugs. I think eventually that's probably what these drugs will fit in the best. There will be combinations. And I think what we will learn, hopefully very fast, is which are the better options to partner them with, what are the optimal dosing schedules, and what's the optimal duration of therapy. Can you step down the dose? Can you give it less often? And can you even stop some of these therapies over time? I project, based on my looking at data, I don't have the evidence to prove this, so don't take this 100% for sure, but I think that probably patients that have been treated with the bispecific antibodies, if they have been successfully treated for an extended period of time or for whatever defined window of time, that they may be able to even go off therapy in a similar manner to what you see for the CAR T-cells. And I think the missing piece here that we are trying to develop are blood-based MOD tests. So if you could give a treatment and you could prove that there is no detectable disease, if you could reliably, say, check every 3 months and make sure there is no disease, I think many patients could potentially be off therapy for extended periods of time. And I think that's an important piece that's currently missing, and we are working on that together with other groups to move that forward.
So, for patients who might be considering a clinical trial involving the bispecific antibodies, what factors should they consider when making the decision?
Well, I think the field is moving so fast forward. So I would say that at this time when we talk here today, the bispecific antibodies are only FDA approved for patients who failed 4 or more prior lines. And we see from all these trials that patients that have their first relapse or the second or the third, that they seem to work very well. But that is only available on trials at the current time. And I mentioned combinations with, I have mentioned the IMiDs and I mentioned the proteasome inhibitors. I should also say for completeness, say there are other drugs as well. I also mentioned 2 bispecifics, but you also have naked antibodies, say Darzalex being combined with bispecific. So you see different combinations. So I would say if someone is looking for a trial in the space of 1 to 3 prior lines, what's available where you live, what's feasible to do, what are the different options, what are the dosing schedules, what are the safety profiles, the side effects always should be looked at in combination with the efficacy. It's a balance between the two. So look at what's available and make wise decisions. If you're not sure, go for a second opinion. I think getting second opinion is usually very well invested time.
Could you speak a little bit about how the oncology social work service at Sylvester Cancer Center, what makes it truly comprehensive?
Yeah, so we do have a very strong team for multiple myeloma. We have doctors, nurse practitioners, nurses, we have pharmacists, we have social workers, we have patient coordinators, we have navigators, we have researchers. We have a very, very comprehensive program. Many times patients are asking about the cost and the implications of the drugs for the insurance component. People are maybe changing from one insurance to the other, or someone is thinking of going to Medicare, and how does that work? So we have people dedicated for our program. So if I get asked this, which I very frequently do, I will always involve my social worker and my finance people to help and guide the patient. So as a doctor, I don't have access to all this information, but I do have a very strong team that will always help me.
I would imagine that's one of the challenges of seeing patients in clinic, and well, I mean, I think one of the challenges I would guess is to getting some patients to clinic, because I have a feeling that some of them feel like that it's overwhelming, it's beyond them, either because of the cost or the amount of effort that has to go into on their part to understanding. There's a base layer of knowledge. There's a language that they have to learn to speak that they don't know. And so sometimes I have a feeling that their patients feel like that they don't belong in this world. So I guess as a follow-up question to that, how do you how do you navigate that with a patient that sometimes that you of course have limited time yourself in order to engage with a patient. You can't solve all those problems, like I said, the psychosocial issues, the mental wellness issues, the diet nutrition issues, and so forth. All of those things, that's not where you are, but it's still your patient.
I think those are excellent questions. So the way I try to organize our care, so I serve as the chief of the program. So I've thought about these things a lot, how we can kind of scale this up and give the ultimate quality for every patient. How can we treat every patient and provide both VIP medical care and all the care and support that you bring up? So the way I try to build our program is that I try to build it in very small cells of professionals, and they are multi-discipline cells. So every doctor works with a nurse practitioner and works with a nurse and works with a patient coordinator. So that's the backbone for a little group that we have. And if the patient volume goes up, if we have more needs, if there are more patients that come to us, we have been growing quite fast, over 20+% every year. When that doctor, nurse practitioner, patient coordinator group gets too busy, then we hire another doctor, another nurse practitioner, a patient coordinator. And at this point, we are close to 10 of those cells. And I think the right size for our program is probably somewhere between 15 and 20. But right now, 10 is a good number, but I think next year we probably hire another 1 or 2, and then we will keep on going as the needs will grow, because there are a lot of patients that need our help. We don't wish anyone to have myeloma, but if they come to us for help, we want to make sure that we can give every patient the same high level of knowledge and experience and care that they deserve. And we are very committed to do that. On top of that, I also have pharmacists that support all these groups I mentioned. I also have a dietitian that support, and we have the finance and the social worker that support us. So really the model we have is that we build a very small group of experts that hold everything together, that everyone knows the patient and the patient knows those individuals. So you don't call a 1-800 number. You call directly or you send a message, and we will respond usually within an hour. If you send through our portal, we will be very, very responsive. Other things that we are doing is that we also organize patient seminars. We have programs where patients can volunteer, or if they want to be part of that, they can talk to other patients. Some patients like that, some patients don't like that, but we have that as an option. And also our program is very active when it comes to different patient organizations. So I'm very inclusive as a person. I welcome all these different organizations, and I've done for a long, long time. So I work with the Multiple Myeloma Research Foundation. I work with the International Myeloma Research Foundation. I work with the Health Free Foundation. I work with the LLS. I work with the Patient Story. I work with anyone who reaches out to us. I always dedicate my time and my attention. And if they have in-person meetings or if they have digital meetings, we always try to help. That's just sort of how we want to share our expertise and our knowledge and help the community.
I love it. Thank you. So one last question. So what advice would you give to patients and caregivers who are seeking information about the latest treatment options for their relapsed refractory myeloma?
So I think I mentioned before, if you have a doctor you trust and you feel like things are going well, work with that doctor and follow that doctor's recommendations. If you want to have a second opinion, it's very easy these days to get second opinions. You can travel, or if you're within states, for the most part, the states would allow telemedicine visits. And I think that's very important that we will be able to continue that. And I know that after COVID, there has been some discussions whether the telemedicine should remain or not. And I think actually all the patient organizations should really gang up together and make sure that the politicians will never be able to change that, because that is going to raise the bars for patients access. If you live in a big city, you have access. If you live in a smaller town, you don't have access. If you have long travel distance, if you are older, if you're frail, telemedicine breaks down all these barriers. So I think, in my opinion, that should be the number one priority for all patient organizations, to make sure that there is no politician that will ever change that, because that's going to cause a lot of patient suffering. And I think in the end, it's going to take people's lives and it's going to have a lot of negative impact. So I think look for second opinions. If you can travel and see someone, or if you have telemedicine, I think that's great. That would be my advice to patients.
Love it. Thank you, Dr. Landgren. And thank you for taking the time to speak to this patient story today.
Thank you very much for having me. It was really a great pleasure. Thank you.
All right. Well, thanks very much. I'll turn it back over to you, Tiffany.
What an engaging conversation. Thank you again, Kenny and Dr. Landgren, for taking the time to deep dive into the latest treatment options for our relapsed and refractory multiple myeloma patients. If you are a patient advocate, a patient, a caregiver, why don't you consider being a voice leader in your community or with us here at The Patient Story, just like Kenny and Dr. Landgren? To wrap up this discussion, I want you to leave with the takeaway that it is important to be empowered so that you and your caregivers can make informed decisions about your care. That includes being educated about the latest treatment options. A reminder, we want to hear from you. A survey will pop up when the program closes, so do not go anywhere. Thank you again to our sponsor, J&J, for its support of our independent patient program, and to our promotional partners for their support. Until next time, I'm Tiffany Drummond signing off, and on behalf of The Patient Story, thank you for watching.